Hello, everybody. This is Kyle Klarich with interviews with the experts, and we're coming to you today from Rochester, Minnesota, to talk about the role of thrombophilia testing in venous thromboembolism. And today, our expert I'm very pleased to be with is Dr. Anna Casanegra, who is an associate professor of medicine at the Mayo Clinic in Rochester, Minnesota, and specializes in vascular medicine. She is the director of the Thrombosis and Anticoagulation and Thrombophilia Clinic. She has trained abroad in Argentina as well as the United States and holds a master's in clinical and translational research. At Mayo, Dr. Casanegra has a clinical practice which really does focus on the topic we're talking about today, thrombosis, anticoagulation. She also specializes in vascular medicine and in the non-invasive vascular diagnoses. So our topic today is the role of thrombophilia in testing in the area of venous thromboembolism. Thrombophilia testing identifies inherited or acquired conditions that can increase the risk of abnormal blood clotting. Sometimes it can help us guide the management decisions for our patients, but who and when to test are key questions, and we hope to address those today in our discussion. Anna, thank you for being here. It's great to have you.
Hi, Kyle. Thank you so much for inviting me. It's a pleasure to be here to talk about a topic that I really enjoy.
Oh, great. Well, why don't we start out with maybe explaining, so we're all on the same page, what is a thrombophilia?
Well, thrombophilia, it's a hypercoagulable state. We know that hypercoagulable states are conditions that make you more prone to develop clots. Hypercoagulable states will be more general, for example, after surgery or during a pregnancy or malignancy. All those are hypercoagulable states. Thrombophilia are hypercoagulable states that are due to abnormalities in the clotting system. And we divide them in congenital or acquired. And congenital are, for example, protein C and S deficiency, factor V Leiden, and within the acquired thrombophilias, we have antiphospholipid syndrome.
Basically, you can have a hypercoagulable state without having necessarily a thrombophilia. Is that correct?
Correct, yes.
And then when you do see this abnormal clotting, you have to think about going down the role of whether there should be a thrombophilia, which would be either acquired or congenital. So what kind of common thrombophilias are there, and how do they differ?
Several common thrombophilias that we encounter, and we like to divide them in our head as strong thrombophilias and weaker or low risk thrombophilias. Within the strong thrombophilias, we encounter protein C deficiency, protein S deficiency, antithrombin deficiency. Those are deficiencies in our natural anticoagulant systems, and those tend to present with a very strong family history, and they're very uncommon, and patients tend to have clots at a young age. And this commonly, finding one of these thrombophilias will have a lot of consequences for the patient care. On the other hand, we have other thrombophilias that are that have a lower risk, such as factor V Leiden or the prothrombin gene mutation. Those are much more prevalent. The factor V Leiden can be present in about 5% of Caucasians, and different prevalences in different ethnicities. And in Hispanics, for example, would be about 2%, 1% in African Americans or Native Americans, and it's more rare in Asian Americans. And the relative risk of thrombosis with this low-risk thrombophilia, such as factor V Leiden or prothrombin gene mutation, is much lower. So there are patients that have these mutations or this thrombophilia and never present with a thrombosis, or they may not have a very strong family history, or they may present with a thrombosis after something else happened, when we have another hypercoagulable situation playing a role in the clinical picture.
I'm wondering, in my practice, how I should and when I should consider testing for thrombophilias.
For me, the biggest question is this something that will impact the patient care? And that is what I like to think. If I order this test, am I going to change something in the patient care or how I counsel the patient based on the results of the test? So in general, what I do is if I have a patient that has an unprovoked clot, we don't have a reason, patient has not had a recent surgery or pregnancy or malignancy or other medical conditions that cause it, it's reasonable to consider it. When somebody has a strong reason for having a clot, we don't test for thrombophilia. And within the patients that have an unprovoked clot or a clot without a good reason behind it, well, we think about how old they are, because we're more likely to find thrombophilias in younger patients, especially the high-risk thrombophilias, and also whether they have a family history. So if I have a young patient with a strong family history, I will probably test. If I have an older patient without family history, I will probably not test.
So you're really relying a lot on age and family history and whether or not they have some other reason that they might have had a clot, like travel or surgery or maybe an underlying malignancy.
Yes, correct.
You
Yeah.
wouldn't probably test.
Because if somebody had a clot after a surgery, for example, we know that surgery is a very strong risk factor, and the risk of recurrence after completing treatment, it's very low. So testing for thrombophilia, it's not going to help us make a decision in terms of treatment. And we know that just statistically, we'll have a 5% of chances of somebody, for example, having factor V Leiden, and that really doesn't impact our decision making in terms of the anticoagulant, but can have a lot of other downstream consequences for the patients. We know that, for example, some of the thrombophilia testing, especially genetic testing, can be costly. So if we're not going to change what we do for the patient, then why order the test? Additionally, some insurance companies will not cover the cost of testing if there's not a medical justification or it's not well documented why the patient needed or how will this impact their care.
Okay, well, that makes a lot of sense. So what does the thrombophilia testing process involve? And what do you consider in the preparation for it for the patient, for instance?
Yeah, for the patient, it's very simple because it's just a simple blood work. But I think the preparation on the provider side of the decision making, it's more important because there are many pre-analytical variables that can affect our results. For example, we should not be testing in the acute setting because when you have an acute clot, there's consumption of your clotting proteins, but also of your anti-clotting proteins. So you can have a low protein C or a low protein S or low antithrombin just because of the proximity of the clot. So rule number one is, with the exception of genetic testing or immune testing, we don't test in the acute period. We wait 3-6 months when we need to make the decision, because at that point, we really don't need that information. The patient needs to be on anticoagulation for a minimum of 3 months. Then the other important thing to take into consideration is which anticoagulant is the patient taking. For example, warfarin will lower protein C and protein S because they're also vitamin K dependent proteins. So it's not uncommon to have a patient in our clinic that said, oh, I have a deficit of protein C and protein S. And then when you look and you inquire a little more, well, it was tested when the patient was taking warfarin. So that really doesn't help us in the management or the diagnosis. And patients get the wrong label and they can pay a high price for that. Being labeled as having a thrombophilia that is high risk, when in reality it was the medication and the timing of the test.
And it's probably not something that everybody is that aware of. I think in my own practice, I have seen people test it during the acute phase, but you would say don't test during the acute phase. They're going to need warfarin or anticoagulation for 3 to 6 months after a DVT, for instance. And then maybe at that point in time, if you think there's a potential suspicion clinically, you would test off of anticoagulation.
Correct, yes. And the only one that we sometimes test during the acute phase, especially if we can get a sample before starting anticoagulants, is when we're looking for antiphospholipid syndrome,
Okay.
because that will take us to a bifurcation in the road, as we know that patients that have antiphospholipid syndrome will preferentially need to be treated with warfarin instead of DOACs. And when we test for antiphospholipid syndrome, most of at least the significant part of the testing are ELISAs for antibodies. So the anticoagulant or the acute setting will not affect those. The lupus anticoagulant part of the testing could be affected by anticoagulants if the patient is already on heparin or other anticoagulation at that point. And direct oral anticoagulants can interfere with the lupus anticoagulant as well. So if you are going to test for something in the acute setting, I think testing for lupus anticoagulant is reasonable if you have that clinical suspicion. But make sure that you document or that you check what was the patient on at the time that they took the blood sample, so we can interpret the results adequately.
How can the results of thrombophilia testing impact a person's medical management and down the road lifestyle?
Well, it depends on the findings of which anticoagulant we found. But for example, if somebody has protein C or protein S or antithrombin, we discussed previously that these have a high risk of recurrence. They tend to be younger patients. So these are patients that we're going to anticoagulate lifelong, even though they may have had a reason. For example, the patient was on oral contraceptives and developed a clot. If we find out that they have a strong family history, they're young, and we found protein C or protein S deficiency, that's a patient that will need to be on anticoagulation lifelong because of the risk of having a recurrent event associated with a protein C or S deficiency.
And what would they be treated with?
Those can be treated with warfarin or with a direct oral anticoagulant. It will not impact the treatment itself, but more the duration of the treatment, and also whether the family members need to be screened or if we need to be more aggressive with prophylaxis if they are in a high-risk situation, or to have a conversation about other high-risk situations such as surgeries or hormonal therapies or pregnancy.
So you do recommend screening the family members once you find?
If we find a high-risk thrombophilia, yes, I do recommend screening the family. For factor V Leiden and prothrombin gene mutation, it's a more challenging discussion. It's a conversation that you need to have with the patient, addressing what are the risks, how is this going to change, how will this impact the family members. I'm especially careful about children, because parents get very concerned about that and they want to test everybody. But genetic testing for these conditions are a double-edged sword. Not everybody that has factor V Leiden will have a clot, so we're not going to treat with anticoagulants just because we find it. And the chances of having a thrombosis in a child are very low, especially unprovoked. So we recommend, especially for children, to wait until they can be involved in the conversation and they can either assent or consent, depending on their age, to make a decision of do genetic testing. Because also genetic testing has their own downsides, and all patients that are tested for factor V Leiden and prothrombin gene deserve to have genetic counseling prior to testing. It can impact, at this point will not impact health insurance, but it can impact life insurance. Right. And also it can impact the patient's psychological well-being. There's studies that show that just by knowing that they have this genetic mutation, even though we know it's very common, patients worry more or have more anxiety and stress when they test positive compared to those who don't.
Well, you've really highlighted some of the downsides of this testing, and it's not just a panacea just to be taken lightly. Well, I've really learned a lot. That you really don't want to do thrombophilia testing unless you have a clot that you feel is unprovoked. That's number one. And that there's acquired and congenital causes, the acquired being the antiphospholipid syndrome. And you can test for that because it's not it's not affected by someone being on anticoagulation if you're worried about it at the time. But there's a lot of other clotting disorders, such as the protein C, protein S, and the antithrombin that you wouldn't want to test during the acute phase, and you'd wait 6 months or so till they're off anticoagulation. And then it seems like the factor V Leiden and the prothrombin gene are long discussions
Yes.
with a very common problem, but also maybe not such a high risk. And so it has to be taken very carefully when you do test for those to avoid some of the downsides that you were just outlining in terms of thrombophilia.
That's an excellent summary, Kyle. The only thing that I want to clarify is that the lupus anticoagulant can be affected by anticoagulants, especially by the direct oral anticoagulants. And it can also be affected if the patient is receiving high doses of heparin. So in doubt, it's always good to have documented what the patient was on at the time that they draw the blood, because we may need to repeat it down the road if it's abnormal in the hospitalization.
Are there any other tips or tricks that you would share with our audience at this point in time?
I think it's important to have a conversation with the patient of why are we testing and what is going to be different after we test. A very common misconception is that we can test for all the thrombophilias that exist, and it's just not true. Approximately 50% of the patients that have an unprovoked clot, even if we test for all the thrombophilias, 50% we will not find anything.
Wow.
It doesn't mean that they don't have something. It means that we don't know, or maybe it's a lot of smaller effects or smaller molecular abnormalities that combined put the patient at risk, but maybe we don't have the right testing for those. So for me, that's also very important to tell the patients, if we decide to test, first of all, know that if everything is negative, it doesn't mean that you don't have something. It means that we don't have a test for that, because it can give false reassurance to say, oh, everything was negative, so I can stop the anticoagulants. And patients that have an unprovoked clot sometimes can have a very high risk of recurrence of anticoagulants. So it's all about a long conversation with the patient of what are we going to do depending on the results and what's the reason for testing.
This is maybe going to be a question to make you look into your crystal ball that you maybe didn't plan to bring with you to this conversation. But do you think over time that we will have more thrombophilias that will be like that 50% of patients that you just alluded to? Will there be, I'm sure there's ongoing research, but is there anything on the handwriting on the wall that we may be looking at and that we can narrow that gap in our understanding about thrombophilias?
Yes, my crystal ball was not working today, but what I think is the first thrombophilias that were discovered were the more severe ones. I think it's easier to find things that have a large effect, and then later times led to the factor V Leiden prothrombin gene mutation. There have been other mutations that have been discovered in more recent years, but we don't test them routinely as part of the panel because they carry a very small risk. So we're thinking more that thrombosis is a multifactorial process, and sometimes it might be a combination, not just testing for one isolated marker. I hope that at one point we'll be able to test multiple genes, multiple proteins, and give a compounded like a compounded thrombophilia panel or compounded risk. So there have been more thrombophilias being discovered. I am optimistic that they will continue to do more. What it's hard is to give what is the weight of that particular thrombophilia in the big picture, and how much will it impact our treatment. The ones that we test are the ones that we know how will impact our treatment, but others, for example, such as elevated factor VIII, has been recognized as a thrombophilia. Sometimes it's associated with inflammation, it's an acute phase reactant, but there are families that have higher factor VIII in general. We don't routinely test for that because it's a very low or mild risk factor, even lower than factor V and prothrombin gene, so it will not change what we do long term.
I think your crystal ball is working very well. So, again, I can't thank you enough for being with us on Interviews with the Experts today to cover a complicated topic, but you made it seem very simple. So thank you for that.
Thank you. Thank you so much for having me.
We'll have you back in the future with your crystal ball next time.
Perfect. I'll tune it up.
All right, everybody. Thank you for listening to Interviews with the Expert coming to you from Rochester, Minnesota. And until next time, have a great rest of your week.